Good evening, everyone. I'm Dr. Gunjan, and my topic for presentation today is newborn history and physical examination. Am I audible to everyone?
Yes.
Okay. So we take up a case scenario. A male child, baby of Parvati, was born to a primigravida mother at term. Baby is now 40 hours of age, noticed to have yellowness of face and trunk. So what is the problem here? What additional history will you ask for? And what action will you take? We'll come back to this case scenario after the presentation once we know better of what history to take and what are the examination findings we require to see. So in history, first comes family history. So whom best to ask for family history? The mother and the family members, the treating gynecologist, and any other family member who can throw light on the disease. So what all can we ask for in family history? First of all, we should ask for any inherited diseases like metabolic disorders, bleeding disorders, polycystic kidney, cystic fibrosis, sensorineural hearing loss. Then if there is any history of developmental disorder, including autism spectrum disorders. We should also ask for disorders that require follow-up screening in family members like development dysplasia of the hip, vesicular reflex, congenital cardiac anomalies, any family history of arrhythmias. Next comes maternal history. So maternal history, first thing we ask for age. So we all know why age is important because higher the age order, more chances of having trisomies and other associated problems. Same with gravidity and priority. More the order of birth, more the problems associated with the childbirth. Then we can ask for obesity history, or we can visually say it as well if the mother is obese or she had been obese during the time of pregnancy or she has gained excessive weight during the time of pregnancy. These things matter because depending on that, the fetal growth is also to be assessed. Whether if she has taken any infertility treatment, and if yes, whether the egg and the sperm were also of donor or self. Then if it is second gravida or third gravida down the line, then we should know the outcomes of the previous pregnancy and whether the previous pregnancies were healthy, if there were any risk associated at that time, if the children are healthy now. Also, we should know the blood group and the RH. Especially in RH negative mother, we should also know the history of anti-D and if she has received anti-D during the previous pregnancies as well. This is to prevent erythroplastosis fetalis in the current pregnancy. Then history of chronic illnesses is to be elicited like diabetes mellitus, hypertension, systemic lupus erythematosus, myasthenia gravis, or any other cardiac diseases or thyroid diseases. This is one of the very important part of the history taking because this plays a major role in deciding what the current baby will be, what treatment the current baby might require. For example, if the mother is hypothyroid, then we have to look significantly into the current baby for risk associated with hypothyroidism. To continue with maternal history, we should also look into the infectious diseases history, which is routinely nowadays done to look for TORCH, HIV, hepatitis B. Then we should look for inherited disorders like G6PD and cystic fibrosis. Any medication she is on, such as select SSRIs, any substance abuse like alcohol, tobacco, or any illegal substance which she is not supposed to consume. Any pregnancy-related complications she has had in the past or she's facing right now. For example, such like if she's undergoing preeclampsia or she's been having excessive bleeding or she's having anemia or any previous surgery or cholestasis maybe, or if she's on tocolytics. So next come fetal testing. This is routinely done around on first and second trimester to screen for aneuploidy of the fetuses. During the second trimester, around 18 weeks, there is a USG survey which is mandatory to look for all the anomalies. Genetic testing may also be indicated in some, like for which amniocentesis, chorionuclear sampling may be done. So we need to know if this has been done and it has to be well documented. Then ultrasound monitoring of the fetal well-being, if it has been done, has to be documented. And if there has been any surgical or fetal medical therapy. This is all part of history which we have to ask if the baby arrives to us. Like if we have not attended the delivery and we have the baby has arrived to us on day 1 or day 2 of the treatment. Then there is intrapartum history, like what is the gestational age of the baby now. Then what is the presentation, whether it is breech presentation, it is face presentation, transverse lie. Then onset and duration of labor, if she has gone into a prolonged labor or not. Then timing since the rupture of membrane. Now, these part of the history is very crucial for deciding the treatment we have to give in. If we know that the membrane has ruptured more than 18 hours, then we have to, there is a clear indication to look for early onset sepsis in the newborn. Then if there is a rupture of membrane, then we should also look for what has been the appearance of the amniotic fluid, if it is blood stain, if it was meconium stain, if it was foul smelling, and any history of fever in the mother, if the mother is on any medications for the current ongoing pregnancy, or if she's been given tocolytics, any and what the anesthetist has been had given to the mother, if she's on steroid, did she receive magnesium sulfate? Then a result of fetal monitoring, that is what was the fetal heart sound prior to delivery. If NST has been conducted, then we should know what the NST suggested. If she has had any complications during the current pregnancy, like excessive blood loss, or if there was shoulder dystocia, what was the mode of delivery, whether it was normal vaginal delivery or if cesarean. If cesarean, what was the indication of the cesarean? If there was any need for vacuum or forceps. Then we can also ask the gynecologist for the placental examination findings. Now we come to social history. Much attention is not given to this part of the history in India, but apart from India, this plays a very vital role in understanding how the outcome of the coming child would be, like cultural background of the family, if they can support the child well, maternal status of the mother, if she is a single mother or if she is a widower, and the nature of the involvement of the family. In cases of single mother, they might not be married, and if the father wants to be involved with the current baby or not. And if in such cases, if there are any other household members who can support, help her raise the child. Also, in case if there is a previous child, then does the custody of the child lie with the mother, or if it is under the child protection. Then we should also know, ask for parents' occupation to know if they can financially support the child. Again, this part of the history is not well elicited in India, but apart from them, it is very crucial to know. Then if there is any identified social support from outside, and if we can ask for the parents' wish for skin-to-skin contact, if they want to breastfeed the baby or want to go for top feed, if they want to go for cord blood banking, then any social support service involvement has been there previously or now. If there has been any history of child protection agencies involvement or any history of domestic violence. So with the help of all this history, a good history can help us reach a good conclusion and also direct our treatment. Now coming to the examination part of the baby. So what are the objectives of the examination? Why do we examine the baby? So first and foremost, to look for any malformation, gross malformations, which can be immediately detected with visual examination. Then to observe smooth transition to extrauterine life from the intrauterine life. Then third point, an overall assessment of baby's condition can be made. So when do we examine the baby? First examination is immediately after the birth. Then second examination to be done with a thorough examination as soon as possible, preferably before first 48 hours. And the third examination is to be conducted before discharge. We have to take care that this examination findings should always be conveyed to the parents, and if possible, done in presence of the parents. Now, coming to examination immediately after birth, what is the purpose of this examination? It is to look for major congenital anomalies, to determine successful transition from intrauterine to extrauterine life, to determine effect of gestation, labor, delivery, and anesthesia on the neonate, to look for signs of infection and metabolic acidosis, to confirm and exclude presence of any findings related to antenatal problems. So immediately after birth, we should check the weight of the baby and temperature. Especially in preterms, it is highly indicated that warm chain is maintained throughout the examination, the resuscitation, the transport. So immediately we can look for this major congenital anomalies like anal opening, cleft palate, meningomyelocele, abdominal wall defects, single umbilical artery, semen crease, and dysmorphic features. A comprehensive examination is to be conducted as early as possible and we should remember whenever the baby's eye is open, one must grasp that opportunity to immediately examine the eyes. Newborn babies usually do not support or go well with the examination when you're trying to do it. So whatever opportunity, whenever you're getting it, grasp it. But also remember to keep it in sequence, like always have a chart or a determined manner of conducting examination so that we don't miss out on something. And then again, emphasizing on maintenance of the warm chain during the examination and to be conducted in well-lit room. And if the neonate is fussy during the examination, it is acceptable to give a gloved finger for sucking onto. So in case of a routine examination, this does not play much role, but if you are dealing with a sick neonate, this gives a quick rapid assessment, stops. We can assess this general sensorium of the baby, the posture, how it is responding to touch. Okay, the temperature, which is 36.5 to 37.4 degrees Celsius. Anything below 36.5 is again hypothermia, and anything above 37.4 is hyperthermia. Usually we say 36 degrees Celsius to 36.5 degrees Celsius as cold stress. Then we should assess the oxygenation of the baby, which is SpO2 and respiratory rate will give us a good idea about the oxygenation of the baby. Perfusion can be determined immediately by checking upon this CFT. Where to check the CFT of the baby? You can use this sternum part of the baby for checking the CFT. And lastly, sugars, especially for the high-risk babies, for risk of hypoglycemia. So depending on the findings on this, we can quickly assess that if our baby is in very sick category and requires immediate attention, if it is sick, or if it can be just routinely examined and sent off home. Next is what examination to be conducted within 48 hours and discharge. This is now we are going into the detailed examination and systemic examination of the baby. So again, coming to the stops, how to go about this gives us this also helps us in follow-up examination. The stops once we are treating the baby and we want to see the response to the treatment, this can again help us in assessing that as well. So how do we see sensorium? Baby's response to touch, uncovering, and consoling is assessed. Hungry baby can only be settled on feeding. So there is no point in shaking, trying other things. If you see the baby is hungry, feed. And then sleeping baby can be often confused for dullness and lethargy, so this is to be avoided. And also, if the baby is sleeping for more than 3 to 4 hours in the first few days, it should be evaluated. Temperature, hand and feet should be checked for warmth with the back of the hand to see if the baby is in cold stress. Again, this is a very crude method. It should always be confirmed with the help of a measurement using a thermometer. Axillary temperature is acceptable nowadays. So a 3-minute axillary temperature can be measured and recorded. And again, normal temperature is 36.5 to 37.4 degrees Celsius. Next comes oxygenation. Saturation, desirable saturation in any neonate is above 90%. And if the baby is on support, any kind of support, be it oxygen, CPAP, ventilator, then we do not want any saturations above 95% unless FiO2 of 21% is being used. So the key message here is to prevent free radical injury, especially in preterm neonates. Then a respiratory pattern. So look for distress, and apnea may be associated with bradycardia, cyanosis, or loss of tone. Especially in preterms, the risk of apnea is higher. And then we can use the scoring system, Silverman Anderson scoring system and Downey scoring system to assess the level of distress and to what support to be carried on to. So Downey scoring is used for term neonates, and Silverman scoring can be used both for term as well as preterm neonates. So what is the normal breathing pattern? Normal breathing consists of 30 to 60 breaths per minute, and there should be no chest indrawing, there should be no grunting sound, there should be no breathing out. So as we can clearly see in the picture over here, there are subcostal recessions. So when assessing baby's breathing, make sure that we count the number of breaths for 1 full minute. So it is normal for babies to have periodic breathing. They take few deep breaths and then give a small pause. Small babies lesser than 2.5 kgs and gestation less than 37 weeks may routinely also have chest indrawing in the first few hours of life, which is why we can use the scoring system to assess the need of any respiratory support. Next is perfusion. So perfusion, nowadays good monitors are available, which gives you a direct indication of the perfusion index. Otherwise, a good assessment of the perfusion can be made with the help of heart rate, blood pressure, and color also helps. A well-perfused baby would be pinkish in color. So what is the normal heart rate? Normal heart rate is 95 to 160 beats per minute. This does not mean that if the baby's heart rate is going low, that it is troublesome. Sometimes baby can be sleeping and have a heart rate as low as 80 beats per minute, and it is under sinus bradycardia. So blood pressure, it is not routinely being measured blood pressure in a healthy newborn, but in case of sick newborns, or if our history elicits that there is chance of any shock or any other neurological deficit, then we have to measure the blood pressure. So blood pressure of about systolic pressure about 60 and the diastolic pressure of about 40 millimeters of mercury is considered normal for term babies. In case of preterm babies, mean pressure of corresponding to the gestational age can be considered for clinical evaluation and further proceedings. Always ensure that adequate cuff size is used for measuring the blood pressure, or otherwise it can lead to faulty readings. So sugars, this is also not routinely done in healthy newborns. And a point of care glucometer can be used to quickly assess the blood sugars. One should always get the point of care glucometer readings cross-examined by a blood test later on. So during the first 3 days of life, blood sugar as low as 45 mg per deciliter is acceptable, and thereupon about 60, minimum of 16 milligram per deciliter. Pulse oximetry, this can be used to screen congenital heart diseases before discharge as well, and target saturations again should be 90 to 95% on support, and at any time it should be above 90%. So where do we measure? Usually right hand is used to measure the saturation, and it can be compared with any of the feet. If there is a difference of 5%, it is quite significant, and we should suspect persistent pulmonary hypertension of the newborn. So coming on to measurements, what measurements are to be done? Usually we do the weight, length, head circumference, and we record it. So it should be taken care that head circumference should be head circumference, there is continuous molding during the first 2 days. So a reliable head circumference can only be determined after day 2 of life. And all these values should be plotted on the graph, and then we can determine whether it is appropriate for gestational age, small for gestational age, or large for gestational age. Now, coming to the systemic examination, all the systemic examination is to be done under the following headings. We've all well versed with the examination findings, inspection, palpation, percussion, auscultation, and there is a new thing in the neonates right now. Those who have been using ultrasound, they know that insonation. This comes last, but it is a very handy thing to be used and can drastically change the outcome and the treatment. So I would not be going into very much detail of the systemic examination as it is covered under the systemic examination topics later on. So cardiorespiratory system. So in cardiorespiratory system, sorry, yeah. So first you assess the color. So baby healthy baby should have a reddish pinkish hue, and acrocyanosis, that is a bluish discoloration of the hand and feet to some extent during the initial hours of life, is acceptable. Also, if you are getting the blood test done, you can correlate with the hematocrit. Less than 42% is pale, more than 65% is again going towards polycythemia and is plethoric. Respiratory pattern scoring system to identify the sick newborn. It can help guide the management. Ausculted with the stethoscope, and X-ray can help us in further evaluation. So we can look clearly differentiate over here between a healthy, normal, and abnormal newborn. So coming to the scoring system, silver method, which can be used in both preterms and terms. This is because this gives a good evaluation of the functional, good evaluation of the FRC level. Hello. So scoring can be done. We look at the upper chest, whether it is synchronized. If it is synchronized, 0. If there is lag, then grade 1. If seesaw, then 2. Similarly, with lower chest, no retraction, 0. If it is just visible, then 1. If it is markedly visible, then 2. Xiphoid retraction, none, 0. Just visible, 1. Marked, 2. Chin movement, similarly, and expiratory grunt. So score of more than 6 at any time means there is an impending respiratory failure. So coming to the Downey scoring, it has a similar scoring based on respiratory rate, retractions, cyanosis, air entry, and grunting. A score of less than 4 means mild or no respiratory distress, 4 to 7 respiratory distress, and more than 7 respiratory failure. Now, while examining the heart during inspection, it is very important to see the precordial activity, rate, rhythm, and murmur should be checked for. Location of the apex beat, whether it is dextrocardia or levocardia, in case of situs inversus or cartilaginous syndrome. Then EKG can be obtained along with the rhythm strip to assess the arrhythmias. Make sure you auscultate over all the 4 areas and record the findings, and closely look for murmurs. It is sometimes it is normal to find a faint murmur in the newborn, especially in the preterms. Always ensure that femoral pulses are checked, and if there is absent pulse, then look for coarctation of aorta. Echo and X-ray may be additional modalities to help further assess and confirm our findings. So, how do we go about doing an examination in an asymptomatic newborn infant? Ensure that full cardiovascular examination has been performed. Then perform pulse oximetry in either foot prior to discharge, ideally after 24 hours. So if the oxygen saturation is more than 90%, 95% in either foot, discharge the baby. If it is between 90 to 95%, repeat after 1 to 2 hours. And if it is less than 90%, further assessment is required. Similarly, if you find a murmur in the child, then if it is a well baby, there will be a soft murmur. No investigation is required. We can follow up after 2 weeks. If it is harsh, loud, more than 2/6, there is heaving, thrill, dysmorphic features are present, then investigation, consider 12-lead ECG and X-ray, and can further be confirmed with the echo. If the baby is unwell, symptomatics, cyanosis is present, shock or failure is signs of failure is present, and the baby has weak and absent femorals, then further investigation is required along with blood gas, chest X-ray, ECG, and an urgent echo is warranted. In all cases, inform the parents about the result. Always keep them in loop, and try to do an initial examination or one of the routine examination in front of the parents. This gives a good sense of bonding, trust, and they know exactly how their baby is being dealt with. Always record all the findings that you have noted. Now coming to thorax, one should always palpate the clavicles during the examination. It is a very vulnerable and often prone to fracture. So shape, symmetry of the thorax is noted. If any accessory nipple is there along the mammary line, if there is any periolar skin tag, and if the breast buds are normal. Coming to abdomen, look for any anterior wall defects, any visible peristalsis, especially in the preterms. They have a thin abdominal wall, and peristalsis is visible, quite visible. And look for any asymmetry. Feel. So how do we feel the abdomen? Gently start with gentle pressure from the lower to upper quadrant to reveal the edge of the liver and the spleen. Up to 2.5 centimeter below the right costal margin can be expected to be seen in the normal neonates. And the spleen is usually not palpable in the newborn. Ensure that your hands are always warm during the examination. On deep palpation, we can appreciate masses and kidneys. So umbilicus, always make sure that we see that number of veins and arteries is viewed, identified, and recorded. Because in case of single umbilical arteries, then we need to further evaluate for renal anomalies. Umbilical hernias are quite common in the babies and usually do not require any treatment, and they heal with time. Also look for any discharge, odor, erythema, swelling around the umbilicus. So in this picture, we can see that newborn having a healthy umbilicus and a infected umbilicus. So a normal umbilicus is usually bluish white in color on day 1. Then it begins to dry and shrink and falls off on its own by day 7 to day 10. And there should be no discharge from the umbilicus. In case of local infection, the umbilicus might be red or the skin around the umbilicus might be red. And in case of possible serious infections, there will be a draining pus or redness, swelling, and erythema. Coming to genitalia and rectum, in male, always measure the stretched penile length, and if it is less than 2.5 centimeter, it is abnormal. Look for hypospadiasis, cordy, scrotal swelling, and hyperpigmentation. In case of swelling, a transillumination should be conducted to differentiate between hydrocele and torsion. Testis should be palpated. Look for undescended testis. Know that about 2 to 5% may present with undescended testis. It should be well documented if both the testes are undescended or if only one testis is undescended, and a review is to be done after a month. So the normal size of the testis may range from 1.6 centimeter by 1 centimeter to 2.9 centimeter by 1.8 centimeter. In case of female, the labia majora and the labia minora should be examined, especially in preterms. The labia majora will not be covering the labia minora. Uh, the size of the majora and minora changes gradually over 2 weeks of gestation. We should note for any redness, swelling, any blood in case of pseudomenses for term newborn. This may be present due to the influence of the maternal hormones. Hymen should be identified and one should look for imperforation. The clitoris to be examined, normal clitoris is about 4 plus minus 1.24 mm. Large clitoris with hyperpigmentation should be evaluated for androgenesis. Also, in cases of male, if there is dark pigmentation of the scrotum, one should look for further evaluate for androgen syndromes. Anus, we should look for the patency, position, and size. Uh, a large fistula can be mistaken for anus sometimes. Now, coming to the skin. So, skin of the newborn can sometimes be dry. It is not very uncommon finding, and it is accompanied with cracking and peeling of skin. Then other skin conditions which we can routinely see or should be looked for or visualized is milia. So what is milia? It is an inclusion cyst filled with debris and a tiny solitary discrete with papules seen on the face and scalp. I'll show you a picture of milia. The first picture over here on top left corner is of milia. The next, we can see sebaceous hyperplasia, which is tiny yellowish white follicular papules commonly clustered on the nose. It is self-resolving within the first few weeks of life. It can commonly be mistaken there can be confusion between milia and sebaceous hyperplasia to an untrained eye. So the second picture on the top right corner is of sebaceous hyperplasia. Then erythema toxicum neonatal, which is a very, very common finding in the newborns due to the developing immunity, developing immunity of the newborn. So it occurs almost in 50% of the newborns. It is seen as yellow-white papules on an erythematous base and appears about 2 to 3 days of life and resolves within the first week of life. So the image over here, third image, which is on the bottom left corner, is of erythema toxicum neonatal. The fourth image over here, you can see this is Navis simplex, also known as salmon patch. So it is basically a capillary malformation located on the forehead, typically V-shaped. It can also be over nape of neck, eyelids, nose, or upper lip. So the ones on face are also known as angel face, which usually disappears in about an year, while those on the nape of the neck is known as stork bite, which may sometimes persist. Then there is transient pustular melanosis neonatorum, which is most common in dark pigmented infants and consists of about 2 to 10 fragile neutrophil containing pustules that are spontaneously break, leaving scales and hyperpigmented macules, which eventually fade. This may be present at birth and needs to be differentiated from bacterial pustules. So this is how a transient pustular melanosis looks like, which can often be mistaken for pustulosis or sepsis. So a baby may have pustule, and if there is more than 10, it is a danger sign and you need to refer the baby urgently. If it is less than 10, then we need to treat it as skin infection. So you can see a small pustule over here. So the common areas where you can see these happening is groin and neck of the baby. Next thing to look for is dermal melanocytosis. This is also seen in dark-skinned and Asian individuals and consists of dermal collection of melanocytes of varying size, macules and patches of black, gray, and slate blue skin. over the buttocks. So do not confuse it with traumatic bruises. And then there is sucking blister. So this is how dermal melanocytosis looks like, the picture on the left. Then there is sucking blisters on hand or forearm of the baby, and they resolve spontaneously. So right top corner, you can see a sucking blister on the baby. And right bottom corner, you can see a baby who is very yellow. So this is a baby who is having jaundice. So jaundice usually presence during the first 24 hours is not normal. It is pathological and needs further evaluation. So always remember, some degree of jaundice is uh, normal finding in the babies after the first day of life. So a quick assessment of the jaundice can be done using the Kramer's criteria as shown in the picture, where if you can see yellowish blanching of the skin over the head, then it is roughly about 4 to 8 mg per deciliter. If it is over the upper trunk, it is about 5 to 12. If it is about the lower trunk and the thighs, then it is 8 to 16. Arms and legs involved 11 to 8, and palms and soles more than 18. So once you determine using Chapman's criteria, it should always be cross-checked with the blood investigations, and treatment should not be initiated simply based on this criteria. So next comes nodes. One should routinely examine for lymph nodes, and enlarged lymph nodes can be a normal finding in 1/3 of the baby. Any size of more than 12 mm is significant. The common sites for lymphadenopathy is inguinal, cervical, and axillary region. And if there is more than two site involvement, then it should be further evaluated. Now we look the extremities. In the extremities, we look for polydactyly, clinodactyly, any webbing, syndactyly, if there is a palmar crease, if there is tibial bowing or torsion, usually seen in oligohydramnios, and if there is any forefoot adduction, also known as metatarsus adductus, and for congenital talipes ignis varus. Joint. This examination is mostly focused around developmental. This examination is mostly focused around DDH. So we do a Barlow's test. It is no longer performed routinely uh, due to leading to overcorrection and overtreatment of the babies based on the findings, and there has been associated risk of avascular necrosis of femoral head with overcorrection and overtreatment. So how was it performed? Hip is flexed to 90 degree and adducted. Examiner places hand on the knee and applies posterior pressure through the hip in attempt to dislocate it. It is positive if hip dislocation is palpable. Autolaminis is performed after a Barlow's test, or in case if there is already a dislocation present, then this maneuver helps in reduction of the dislocated hip. So how is it performed? Hip is flexed to 90 degrees and abducted. Examiner places finger laterally over the greater trochanter of the hip joint, applies anterior pressure over the trochanter in an attempt to identify a displaced hip that is relocatable. It is positive when there is a sensation of palpable trunk that represents the reduction of the dislocated hip. There is also a Galeazzi sign, which is position child in supine with hip and knees flexed, heels to the bum. Affected side knee is lower due to posterior displacement of the femoral head. Positive if inequity in the height of the knees. As illustrated in the diagram, we can see all the three tests: Galeazzi, Barlow, and Ortolanis. So for the DDH, how would we go about? Ask for any risk factors of DDH, perform a Ortolani and Barlow. If it is negative, clinical skin, inform parents of the result, no action is required. See screening pathway. If it is negative clinical skin, but positive risk factors are present, and inform the parents of the result and get an ultrasound done after 6 weeks. If it is positive, inform parents about the result, then and get it examined by an expert. So after an ultrasound, if it is negative, then no further investigation is required. If it is equivocal, then rescan after 4 weeks. And if it is positive, refer to a specialist. Coming to spine, neonate is to be examined with face down for spine examination. Look for any pyramidal sinus tract. Local skin findings is to be noted. If there is a meningocele or a meningomyocele or a spina bifida, uh, presence of sacral dimples can be quite common and only need further evaluation if it has a depth of more than 0.5 centimeter or is located more than 2.5 centimeter from the anal verge, or if it is associated with any hypertrichosis, subcutaneous mass, or caudal appendages. Now coming to head and neck examination. In head, first we come to scalp examinations. In scalp, we look for cuts, abrasion, bruises, and puncture wounds. This examination, during this examination, it is quite common to find swelling present in the baby scalp, which can be caput succinate or a cephal hematoma or a subgaleal hemorrhage. Rarely cutis aplasia congenita or navis sebaceous may be identified. So this gives us a good idea about where the swelling is present in case of caput, in case of subgaleal hemorrhage, and in case of cephal hematoma. Skull bones, examine the occipital, parietal, and frontal bone. Examine the sagittal, coronal, lambdoidal, and metopic suture lines. Mobility rules out planus anostosis. We should look for plagiocephaly and craniotapes which resolve spontaneously. Now coming to fontanelles, it should be routinely palpated and noted. If there is a large fontanelle, this can show that there is a delay in ossification, and some of the factors could be hypothyroidism, trisomy syndromes, intrauterine malnutrition, hypophosphatemia, and osteogenesis imperfecta. Fontanelle should be seen in upright or sitting position, and if it is tense or if it is full, then it warrants further evaluation as there is presence of raised intracranial pressure. Now coming to examination of the eyes, one must look for all this if it is present or not. Now, as I told earlier, that it is very difficult for us to get the newborn to get its eyes examined. So whenever the opportunity comes, one must seize it and check for the following findings. If there is any ictrum, if there is any scleral hemorrhages, conjunctival exudate, what is the color of the eyes, if there is any coloboma present, extraocular muscle movement, pupillary size, equity reacting and centering to be noted, red eye reflex, cataract. Puffy eyes often make it very difficult for examination, and one must do an examination at a later time. So after a careful history, we can have both eyes examined, and for if there is a red eye reflex present, then it is a normal finding, and this can be conveyed to the parents. If red eye reflex absent, there is a possible congenital cataract, and further evaluation is to be done. If there is a white eye reflex, then there is a possibility of retinoblastoma, and further investigation is warranted. Now in head and neck, next we should look for ear. In ears, the size, shape, position, auditory canal, preauricular sinus, pits, and skin tag are to be documented. In nose, patency of the nares, septal injury, corneal atresia, and if there is any visible deformity is to be noted. Next comes mouth. In mouth, we look for cleft palate, extreme pulse, mucosal, sublingual ranula, alveolar cyst, absent or bifid uvula, natal teeth, and ankyloglossia, also known as tongue tie. In neck, we should examine the neck. Uh, the newborns have a very short neck, so one should always lift the neck for proper assessment, and it is a common site for pustulosis. So one should look for the range of motion if there is presence of any goiter, if there is a thyroglossal tract or brachial arch sinus tract. In jaw, look for micrognathia, retrognathia, or receding chin. Now coming to the neurological examination, it can be divided into autonomic, motor system, then state, and responsiveness. So in autonomic, we'll see vital sign stability. There is neurocutaneous stability. So pink versus mottling or cyanosis. So pink baby is stable. Mottling cyanosis means there is some instability present. And look for gastrointestinal stability, jitteriness, all the hypos like hypocalcemia, hypomagnesemia, and any use of in vitro drug exposure, like use of SSRI, tobacco, cocaine. So this can present as jitteriness in the baby. Then look for the myoclonic jerks, sneezing, hiccups, and frequent yawns. So this, if there is frequent sneezing, hiccups, and frequent yawns, it can be indicative of any autonomic dysfunction. So Finnegan neonatal abstinence score can be scoring system is there, which can be used to determine the instability. So this is the chart one can use to plot. So how do we read this chart, and when it is to be done? So it should be performed ideally within 24 hours of birth, and the score is to be repeated every 3 to 4 hours. So two consecutive score of more than equal to 12, or three consecutive score more than equal to 8. If it is present, then we should see if the mother on any was consuming any opioids. If yes, then the following treatment is to be started. If no, then the following treatment is to be started. If the screen was negative, if it was no, then you continue your monitoring every 3 to 4 hours. Whenever you find anything more than equal to 8, then the same pathway is to be followed. Coming to motor examination, you look for the extremity, axial tone, any asymmetries, like in cases of brachial plexus injury, the hand to mouth efforts, tucking, bracing, grasping, arching, playing, hands playing, and all the primitive reflexes. So the primitive reflexes can be elicited in the following manner, namely glabellar reflex, the snout reflex, rooting reflex, sucking reflex, palmomental reflex, grasp reflex, Moro's reflex, gallant reflex, asymmetrical tonic neck reflex, Babinski reflex, walking reflex, and placing reflex. So state of the baby is to be noted under neurological examination. That is, if the baby is in deep sleep, light sleep, if the baby is drowsy, quick alertness, if the baby is active, crying, fussy, and responsiveness. Responsiveness is to be assessed. That is, if the baby engages, ability to fix or follow face or voice, response to inanimate stimuli, response to sound. Posture plays a very important role in the neurological assessment. The normal resting posture of a term newborn is loosely clenched fist, flexed arms and hips and knees. Small baby less than 2.5 kg and less than 37 weeks, the limb may be extended. Babies born in breech position may have fully flexed hip and knees. The The legs may even reach near the mouth. So this is how a breech-born baby would be look like when it is resting. And this picture shows an abnormal posture. So we can see that the left hand is flexed, but the right hand is extended. Left foot is flexed, but the right foot is extended. So coming to till now, all the examinations were related to sick newborn. So if there is a normal newborn who needs to be assessed, then feeding gives us a very good assessment. So we look for the positioning of the feeding. Head is in line with the body. The weight should be well supported. Abdomen touches the mother's abdomen, and the baby should be turned to the mother side. So this positioning points are for the mother to keep in mind while breastfeeding the baby. Uh, and a good attachment is where the mouth is wide open, lower lips is everted, little areal is visible, and chin touches the mother's breast. So it is normal for the baby to do the following. It can pass urine for more than 6 times a day. Uh, and also it can pass 6 to 8 watery stools in small quantity, in small volumes in 24 hours. Female baby may have some vaginal bleeding for a few days during the first week of after the birth, and it is not a sign of problem. It is due to the under the influence of the maternal hormones, and the babies usually lose about 10% of their body weight during the initial days and regain it by 7 to 10 days. So what are the danger signs? If the baby is not feeding well, less active than before, fast breathing more than 60 per minute, if there is moderate or severe chest indrawing, grunting, or convulsions. Floppy or stiff baby, temperature more than 37.5 or less than 35.5, umbilical draining or any redness, more than 10 skin pustule, bleeding from umbilical stump. Key messages: smoking. Tobacco smoke harms your baby health and increases the risk of dying from cord death or SIDS. Protect your baby by eliminating exposure of your baby to secondhand smoke. Breastfeeding, always the best thing to do. Routinely give it till 6 months. And if the mother is unable to feed or during some circumstances, then formula may be preferred for the first 6 months. SIDS prevention, always place your baby on their back to sleep, even for naps. Place the feet to the foot of the cot and with head and face uncovered. Prevention of injury, watch your baby at all times. Children do not understand danger. And always correctly fitted car seats in case of traveling and all, always correctly fitted car seats are to be used. Routinely immunize your baby to prevent it from diseases. Some more of the danger signs are vomiting, irritability, lethargy, decreasing urine, stool, raised temperature. So we come back to the case scenario one. A male child, baby of Parvati, was born to a prime gravida mother. At term, baby is now 40 hours of age, noticed to have yellowness of face and tongue. So what is the problem over here? We know that the baby is having icterus. So since it is 40 hours of life, we know that it may be a part of physiological jaundice. So what additional history would we ask? We can ask if the mother is having any G6PD deficiency or if she is hypothyroid. And what action will we take? We'll get it evaluated with a blood checkup and correlate with the NICE guidelines. Second scenario, a female child, baby of Surrey City, was born with weight of 1.5 kg. Baby weighs 1.3 kg today on day 2 of life. So what are our concerns over here? There is a loss of 200 grams. 200 grams in 2 days. So as we said, up to 10% over a period is acceptable. This is way more than 200 grams. So what could be the problem over here? Inability or faulty feeding could be the problem here. Early onset sepsis can be a risk over here. So what additional history will we ask for? We can ask for if there was any PROM prior to delivery, if the if the baby was preterm, the gestation of the baby, we can ask for feeding history, improper feeding, or if inadequacy of the milk. If she was having any burning micturition, if we can ask the gynecologist if there was any elevated TLC. And what action would we like to take over here? We need to immediately admit the baby and do the routine workup to rule out sepsis and other causes. In conclusion, all the babies must be examined at birth as soon as possible, preferably within first 48 hours of birth and before discharge. And one of these examinations should be conducted in the presence of the parents. A systemic approach with consistent order should be followed to prevent practitioners from missing out on any signs and symptoms. And it is advisable to maintain a checklist. Thank you.
Dr. Gunjan, there is a question in the chat box where
Yes, sir.
Nikala is asking, what is the commonest cause of jaundice in first 48 hours, right, in your country? So probably she is from another country.
So if it is within the first 24 hours, it is not physiological. It has to be assessed. It is always pathological during the first 24 hours. And it is only after 24 hours, then it can be physiological.
Okay.
So it is because of the lack of conjugation.
Yeah. Second thing is, second question is, what are the investigations which need to be done in a child with single umbilical artery?
Usually we go about looking for renal anomalies. This is just a part of the examination we are covering. We are not covering the diseases and the things in this scenario.
Yeah, well, very well said. Same answer goes to Dr. Varun Ramesh as well, that we are not covering management or diseases in per se. And what we are covering here is how to go ahead with neonatal examination and history taking. Anita ma'am, anything else we need to add to the present scenario and discussion?
Hello, I would say nice presentation, Dr. Gunjan, but it was too elaborate and there were points which were not necessarily to be looked for, like the things and
मैम
that
ना
kind of
हटाओ
things.
इसके
Those be removed and we should focus on the important points. And in the newborn examination, I would say the examination is like when you are dealing with a case which is in the ICU, that is a different setting. When you are dealing with a case that is a feeder and grower, that is a different setting. So all this examination is different in that way. And you discussed very comprehensive, and I would appreciate that. But the what is the respiratory distress? We could have short videos on that. And neurological examination of the newborn as such is a very long subject, and that was probably was not discussed in much detail, because most of the newborns would have some neurological situations which should be assessed in detail. So what is the neurobehavior, how the tone should be examined, what is the Dubovich performer for the neurological examination, because systemic examination and head to toe examination is a very small part of the overall examination. So that should be dealt in much detail. And then we have a few questions in the chat box, like what is the commonest cause of jaundice in first 48 hours in our country? Still, it remains RHI somnization. In the recent guidelines, is to be added that management of umbilical cord. So umbilical cord, delayed cord clamping should be practiced. That would we say. In fact, now the strategy is also coming up in case of perinatal asphyxia, and with cord side resuscitation is also being tried in trials. So the delayed cord clamping is the key to the present delivery room management. What is the investigation to be done on the first day of life in single umbilical artery? I would first say that you examine the sorry. So you examine the whole and then decide about the examination. In fact, in the 8 to 12% of the cases, it can be associated with the genitourinary and heart anomalies. So examine first, look for saturation, and then decide about the extensive ultrasound KUB can be done. because that is easiest. And if echocardiography is practically easily available at your center, then you could do that. Management of congenital hydrocele found incidentally, you just need to wait and watch. That's all about this. But this topic of the history and examination could be more simplified. That is my suggestion. If some of if any of the fellow have some questions, they can still ask. I would be happy to answer.
I think what ma'am has suggested, Dr. Gunjan, you have to do a repeat presentation on the neurological examination per se with a case-based format in which what you have done. I think, ma'am, that will cover the topic.
Uh, and he can well do, and if you want, I can do that.
Sure, ma'am. That will be even better.
That
If you can,
that would be
that will
beneficial
that
for everyone.
yes, ma'am.
That I have a simplified short present. I would not do in much detail, but I would try to do it simplified manner. So I think that is an important part, and
Yes.
mostly the fellows lack in that because it is not often discussed much in detail. So